Hi everyone, my name is Pramila Upadhyay and I have been doing my master's practicum project as Montage Health. Um, let's begin with the topic of my presentation today. The topic of my project is exploring the causative factors that is driving hospital readmission and establishing preventive strategies in reducing readmission. The objectives for my projects are to explain about the practicum site, to define and clarify importance of decreasing readmission rate, explain about penalties related to readmission, compare Montage Health readmission rate with Vizient benchmarking, discuss the finding from chart review, to describe the causes of readmission, establish communication plan with stakeholders, summarize budget and resources for the project, recommend the readmission preventive strategies, to explain about project evaluation tool, discuss about quality and safety education for nurses competency achievement, and describe the project's outcome, limitation, and lesson learned. Let's begin with giving you the brief description on the organization where I did my practicum. Montage Health is a non-profit healthcare organization located at Monterey, California. It have 175 bed community hospital, and it is also known as CHOMP. Montage Health have 90 provider group, which includes primary care, specialties, rehabilitation services, outpatient physical therapy, outpatient diagnostic imaging, outpatient laboratory services, skilled nursing facilities, it is called Westland House, and collaborative care services supporting all the Montage Medical Group patients. So the Montage Health have been prioritizing their discharges through multidisciplinary rounds, which is conducted every morning at 9 a.m. And this multidisciplinary group, there are doctors, there are charge nurses, there are discharge planners, inpatient rehabilitation service people. All this group discuss about the possible discharges, and either those discharges will go to home, or they might need home care services, or they might need to go to skilled nursing facility for the rehabilitation. The goal for doing this is reducing the readmission rate. Still, they are doing all this, but still there are a lot of challenges with timing, coordination of the care, and frequency of readmission. I have been attending that multidisciplinary round, and also from there I got like this project was derived from like I was very interested, like what is the readmission, why it's important for the organization, and what does it do. So I decided to do project in the readmission rate. Next, let's give you some background on readmission. So readmission means patients who are readmitted within the 30 days of discharge from their index admission. The index admission is referred as the initial hospitalization, and there is all causes unplanned readmission, which means readmission within 30 days of discharge, regardless of the hospital and diagnosis. That means if one patient came to one of the acute care facility and they were discharged, but they went to some other healthcare facility, and that is also considered unplanned readmission. and it doesn't matter which hospital and what diagnosis they go back with. But if they come back to the hospital within 30 days, it's considered the readmission. But it only excludes the planned procedure. This definition was from Center of Medicare and Medicaid Services. So readmission cost a lot of money. Annually in United States, it costs 15 to 20 billion dollars. That's a lot for the for the healthcare system. So preventing readmission is the most we need to try to prevent and decrease the rate of readmission. This helps to improve the quality of care, and also it saves the cost. And there is also, like I mentioned about the planned procedures. Those are the intentional readmission within 30 days of discharge. So it's not counted as unplanned readmission. So if there is the organization who have a higher rate of readmission, they need to pay a lot of penalties. Center of Medicare and Medicare Services introduced the program called Hospital Readmission Reduction Program. In short, it's known as HARP. So it's a value-based program, and it is used to measure 30 days unplanned readmission. If any healthcare organization have a higher rate than their set standard, then they have to pay a lot of penalty. So the payment adjustment factor is weighed against the hospital performance and across the readmission measure for all the discharges in applicable fiscal year, no matter what the condition of hospital is. Now let's go to the timeline of the project. We had 4 months to conduct the project. So I used the Gantt chart, which is I found it very useful to keep a track of tasks and milestones, and it provides visual presentation and easy to execute the plan. So you can see here, this is example of Gantt chart. So you can, it's different colored, and you can have the project start date and end date, and also it have the percentage of completion. So it's a very easy tool that we can use to keep a track of the project. Usually the project phase consists of 5 phases: initiation or design, planning phase, implementation, monitoring, controlling, and evaluating, and a closing phase. The initial phase is the first phase, which can consist of pre-conference meeting, need assessment, reviewing of current workflow, developing goals and objectives, developing project proposal scope and deliverables. Second phase is a planning, which can include project schedule, work breakdown, chart reviews, need assessment, gap analysis, education development, risk management, making a stakeholders communication plan. That could all come under the planning phase. The third is implementation phase. It's also the project execution phase or going live. And after going live, we need to track. We could track by using the checklist, milestones, and task. And then there is a continuous need of support and feedback. Next is monitoring, controlling, and evaluating phase. We can use PDCA cycle. That's one of the example. And also we can evaluate project progress against goals and objectives. And there we can also include the reassessment on monitoring phase. The last is closing phase. The closing phase consists of verification audit, review of final deliverables, project milestones, checklist, project closeout meeting, after action review. It also consists of lesson learned, and then after there will be final report, and the last thing is project signing off with the leadership. Let's discuss about the quality measure in Montage Health. At Montage Health, quality is measured along 4 dimensions: patient safety, clinical quality, experience, and resource management. The readmission is also considered as one of the quality metrics, and data are analyzed using the Vigient Clinical Database and Resource Manager. The reports are benchmarked against like organization with the database. The reports are available under service line dashboard. This is an example of the safety and quality dashboard. This is CHOMP's quality safety and quality dashboard for 2023. Here we can see 30 days all-cause readmission rate it's benchmarked against the Vigient, and here you can see the Vigient benchmark scoring is 9.4, where CHOMP is at 11. So it's CHOMP have higher rate, so the admission rate need to go down for 30 days all-cause readmission rate. And similarly, 7 days all-cause readmission rate, the Vigient benchmarking is 3.4, whereas CHOMP's readmission rate is 4.1. So also 7 days cause is higher than the benchmark, so there we need to bring it down. So those are the clips from the CHOMP's safety and quality dashboard, where you can see this is a Vigient benchmarking. This is the same as above, and where you can see 11 and 4.1. This is how we can find out that CHOMP is the Montage Health or CHOMP needs utmost need for improvement within the 7 days of discharge. It is also published in their executive summary from October 2023 that Montage Health need to work on their decreasing the readmission rate. If the patient are readmitted within 7 days of discharge, the hospital are considered responsible. These patients were discharged too soon, or the discharge education was not provided, or there could be many things. So if patient comes back within 7 days, it falls under hospital. So Montage Health is focusing on decreasing the rate of readmission within that 7 days. For this project, I also did a chart review for the patients. So the patient population, I had 40 patients who were randomly selected from the list of discharged patients during second week of November. This discharged patient chart was followed for 30 days. I followed them for 7 days, 14 days, 21 days, 28 days, and 30 days to find out if those patients who were discharged on second week of November were readmitted within that 30 days window or not. So all this information was logged into Microsoft spreadsheet to keep a track of discharges. So next we're gonna look at the results of my chart review findings. So going on to the demographic characteristic of readmitted patient. As I mentioned earlier, I had a sample size of 40. Out of 40, 19 patients got readmitted, and out of 19, you can see in the bar diagram, 11 were male and 8 of them were female. Likewise, with the age group, there were 10 readmission from age group 61 to 80, and 4 of them were more than 80 years, and 3 of them were from 41 to 60 years, and 2 of them were from 20 to 40 years, whereas there were no readmitted patient from age group younger than 20. Next, with the ethnicity of the readmitted patient. Majority of the readmitted patient were from white ethnicity. There were 12 people who were readmitted from white ethnicity, whereas 6 of them were from Hispanic, and there was 1 from other, and none of them were from Asians. Also, these results might affect because the demography around the healthcare where this Montage Health is located is the white majority. So this result shows more readmitted patients were from white ethnicity. Next, determinants associated with readmission is admitting diagnosis. I was looking for what would be the disease that would have higher readmission rate. So in my chart review, I found cardiovascular disease was the one of the most higher. Out of 19, 8 had cardiovascular disease, 4 had orthopedic problem. 1 of each were respiratory illness and stroke and TIA, whereas there were 5 readmitted patients from other disease category like wound, back pain, abdominal pain, and etc. Next bar diagram is about days from discharge to readmission. So my goal was to find out which day is most prevalent for the readmission. So according to the finding, there were 14 readmission within 0 to 14 days. So there were 7 each on from 0 to 7 and 8 to 14 days, and there were 5 readmission from 15 to 21 days, while there were none after 22 to 30 days. So the finding is suggesting that 0 to 14 days is the most critical for a patient to be readmitted. Next, determinant associated with readmission is social determinants and discharge disposition. Let's talk about social determinants. The primary social determinants for readmission was found to be lack of education, and alcohol and drugs was the next, and being non-compliant with self-care and medication were also the factor for readmission. In addition to that, there can be several other social determinants like smoking, housing problem, family support, and patient economic situation that can cause more readmission. If you look at the discharge disposition bar diagram, out of 19, 12 of the patient came back to the hospital who were discharged to home, whereas 4 of them were from home with home health services, and 3 of them came back to the hospital from skilled nursing facilities. This is the last determinant associated with readmission. It is the comorbidities. The result shows out of 19 readmitted patient 13 had comorbidities and 6 had no comorbidities. So the comorbidities include heart failure, diabetes mellitus, cerebrovascular disease, chronic obstructive pulmonary disease, pneumonia, renal disease, and cancer. So there is also that people having comorbidities are more likely to come back to the hospital within 30 days of the discharge. This slide is a summary of readmitted patient characteristic. So total sample was 40, where 19 got readmitted, 11 were male, and 8 were female. Majority like 61 to 80 years, and they were from white ethnicity who got readmitted. The cardiovascular disease was the most prevalent cause. Readmission rate was high within first 14 days of discharge, and people who were discharged to home came back to the hospital within the 30 days window. And the last one is lack of patient education, and patient with comorbidity has the higher rate of readmission. After the results, let's discuss about the causes of hospital readmission rate. I used the fishbone diagram to put down the causes of hospital readmission rate. You can see in the fishbone diagram, there are main component: hospital, the inpatient admission, there is outpatient, and there is a social determinants, and there is patient's family member support. And under the hospital, the causes can be short staffing. The healthcare field is mostly short staffed, and we still need a lot of people. Like every day we need a lot of, if there is more people in the healthcare setting, then more care the patient can get. And side effect from hospital acquired infection, there is always a chance of getting hospital acquired infections. The medication and procedure error could also be cause of the hospitalization within 30 days of discharge. The culture of the organization and the patient is the another one. Staffing model and poor communication. The communication plays very important role in decreasing the readmission rate, because there might be many people who doesn't know what are the consequences, or they are scared about the disease what they have. So if the nurses and all other healthcare team members give good communication to the patient, then there is a chance that they wouldn't come back within that 30 days window. Outpatient. Similarly, in the outpatient, a lot of patient even doesn't know when to go to outpatient setting and when to visit the emergency department. So sometimes they are like, okay, something happens, they would just go to emergency room and they get admitted. So there are certain things like a little fever or like ear infections, that are like minor. Then they can go see their primary care provider first, and if they think they need to go to emergency and get admitted, then that could prevent from this unplanned readmission hospital rate. In outpatient too, staffing can be another issues, and distrust between the patient and the provider could also play the role to get the patient come back to the hospital within 30 days of discharge. And in outpatient, the problem is long wait times too, and it is all about the communication gap. So if we can improve the communication and maintain a trust, then people will start going to outpatient rather than going to emergency room, even for the minor causes. The other factor is social determinant, and then socioeconomic factor plays very important role, like education, employment, income, safe community, family, and social support plays very important role. If they have a help at home and family supportive, then they can get better sooner. And also there is a behavior like alcohol, drug, diet, and exercise, and healthcare, access to healthcare, and quality care. Those factors can also prevent from 30 days readmission. And the last one is patient and family member. We also discussed earlier that if patient have enough support at home, and also they have financial economic support, and they are financially and economically sound, they have insight for their like disease, what's going on, the importance of the medication, and if they are not postponing their visits, and they know how those regular visits are important, also that could decrease this 30-day readmission rate. And the other cause can be age, and then complexity of the diagnosis and morbidity. If the hospital can look at these factors, then removing these factors can help prevent 30 days readmission rate. Now, after we know about the causes of the readmission rate, to conduct the project, we need to make the stakeholders communication plan, like what could be done to prevent the readmission rate. So we have to include stakeholders from beginning of the project, so they are aware what is going on, and what might be needing in the future, and if in case something need to be changed, then there is no resistance with the stakeholder and upper management. So it's good to include the stakeholders in planning phase, like analyzing on the analysis, collaborating. They will be involved in project approval, kickoff meetings, and then they should also know about when the project is going to start. They will be equally helpful in building the team, like building the team for the project. And one of the main thing that we need to include them is giving them a status, like weekly status, budget update, or any kind of milestone reviews, like the quality, or software like development or updates. So if we can provide them brief summary of this, what's going on the weekly basis, or like bi-weekly basis, then they will be on the same page as all the project team members. The stakeholders need to be included in the meeting, the team meeting before going live, so they can give their feedback if needed. Continuing on stakeholders communication plan, after going live, like our plan should be doing a daily huddle for like achievements, barriers, or like what are the milestones that's targeted for the week. We can also work on key performance indicators, like how is discharge doing around the unit versus like organizational, like what is the rate, how much are we being successful discharging them by 1 p.m. or those kind of key performance indicators should be looked at. And also the other thing is, if we are trying to decrease the readmission rate, we need to look at the other side. Is the length of the stay increasing, or what is the status on the length of stay? They can go together sometimes. Also, we can do as needed meetings, and for the readmission could be like it can be a like bigger project. It can be done like once. It need to be done in the cycle. So I think PDCA cycle will be good to use, one of the good tool to use. So it helps on continuous monitoring, and also change if anything, or like if modify if any needed, like in step 1, step 2, you can change and modify accordingly what are the findings. So if you include stakeholders in the communication plan, all these steps, it will be very easy to work with the stakeholders and upper management team. This is our overall project communication plan. It includes kickoff meeting and who are the attendees, goals, frequency, method, and responsibilities. So for the project kickoff meeting, it will be all team members and stakeholders, and the goal would be introduction of the project. It is one-time event, and it would be conducted in-person meeting, and the responsibility is project manager. Likewise, there is project team meeting, there is status report, team meeting on and budget meetings, quality and risk review, and milestone review, as needed meetings, meeting before project execution or going live, milestone review, and project closeout meetings. So on the attended side, you can see the frontline nurses, all team members, and on the milestone review, you have all stakeholders and all the team members, and as well in project closeout meetings, all team members and stakeholders, and it includes the frequency, and there is how are you going to conduct those, like the meeting before project execution will be in person, whereas a milestone review could be in person or video conference, and status or report and team budget review could be done via email. Like the last one, the project closeout meeting would be good if done in person, and maybe done in like presentation form. So this is our overall project communication plan. Next is estimated budget plan for the for this project. 13,350 is estimated budget plan, which include education pamphlets, hands out, training, supplies, technologies, HIT personnel, registered nurse, travel, and miscellaneous. And on this budget plan, directors and assistant directors are salaried positions, so their time and their budget are not necessary to include in the budget plan. Next is recommendation of implementation plan and preventive strategies to decrease the readmission rate. So with the time limitation, I did not have chance to implement my project in clinical setting. So I'm recommending the implementation plan and preventive strategies that can help to decrease the readmission rate. The first recommendation is using the process mapping to reduce the readmission rate. The process mapping is the visual representation of information and ideas, and it helps to identify problem and possible solution. So this is my process mapping. It is, when I put into the slide, it's little blur, so I'm gonna go to the next slide, where I have break down this process mapping into two pictures, so I can explain this more clearly. So the process mapping to reduce the readmission, it begins from the admission. When the patient comes and get admitted in the hospital, then next step is knowing your patient, like why are the patient there, what is the diagnosis of the patient, are they newly diagnosed or it's a chronic, and what is the source of admission, are they from home or are they from skilled nursing facilities. Next step would be determining the social determinants. Does that patient have some social determinant needs, like they have trouble with housing, they have trouble with behavior issue like alcohol, smoking, they don't have a job. So if yes, go to the next step and then connect and provide community resources as per their social determinant needs. For example, if they do not have the housing, connect them with a social worker so they can find the housing during their stay, so we can discharge them on the right place. If they do not have the social determinant need, go to the next step, which is finding the chronic condition. Does that patient have chronic condition? If yes, go to the next step and if engage all the team members ahead of time in the care of coordination. For example, if the patient have heart failure, connect with the heart failure coordinator. If they have diabetes, connect them with the diabetes coordinator, and do everything like open communication, set the goal during the stay, and they need to begin from the beginning of the admission, so the patient get enough time and enough information. If that patient do not have any chronic condition, go to the next step. Identify and assess the risks for readmission. Is the patient high risk for admission or they are not high risk for admission? To find that, we can use the tool. There are different tools available. For example, modified LACE scoring or hospital scoring to find out if they have higher risk of admission. If they score like higher, then you can go to the next step, make the individualized patient-centered care plan, including home health, dietary plan, or whatever their need is, work on that needs. And there comes the next step. If they do not score higher, then they, during that hospitalization, use the teach back method to educate the patient about chronic condition, about their disease process and what they need to know about the disease. After that, prior to discharge, prepare your patient, teach them about the disease process and include them in their own care, include the family member in the care so they already know what to do after going home. And right before the discharge, prepare them for the transition, what they can do at home, when to come to emergency room, when to go to outpatient clinics. And on the day of discharge, give the right medication list to the patient and explain how often they have to take it, what's the importance of medication, provide educational materials on the disease process and medication if they need, and also explain them about follow-up care, provide the phone number of the place where they are supposed to go for their follow-up, and ask them to call the place if they didn't hear back like within a week. And also usually they are told that they need to see their primary care provider within 2 weeks of the discharge. And then there comes the discharge, and after discharging, then there is a follow-up monitor that involves transition care manager. They need to confirm like correct phone number on the list, find the right person to talk, and make sure they can make their appointments, and also connect with home health agencies, and if they need any kind of post discharge help, that can be helpful in preventing the readmission within 30 days window. The next thing that can be done is using the readmission screening tool. Currently, Montage Health do not use any of the readmission scoring tools, so it can be helpful using the readmission screening tool. I have listed the two different kinds of readmission screening tool. The first one is called modified LACE scoring, and the other one is hospital scoring. The modified LACE scoring uses 4 variables: length of stay, acuity, comorbidities, emergency visit in last 6 months, whereas hospital scoring have 7 variables, which include hemoglobin at discharge, discharge from oncology, sodium level, pre-procedure during stay, index admission type, number of hospitalization, and length of stay. I also, when I did my chart reviews, I also calculated the both modified LACE scoring and hospital scoring for each individual patient, and I was able to draw the conclusion that which performed better at predicting the readmission score, which I'll be presenting in the following slides. So modified LACE scoring score calculation had total points of 0 to 19, whereas hospital scoring have total points from 0 to 13 points. They are categorized into 3 risks. So low risk, which is 0 to 4 points, intermediate risk, 5 to 10 points. High risks are those who scores more or equals to 11. Whereas in hospital scoring, the low risks are 0 to 4 points, intermediate risk is 5 to 6 points, and high risk patients are those who score more or equals to 7. So when comparing my results, result for modified LACE scoring and hospital rescoring, you can see the results in the box. The positive risk score and positive readmission out of 19, 13 got a high score and they were readmitted. Those are 32% of 32%, and the patient with positive risk score and they were not admitted were 12, which is 30%, and the patient who did not score but get readmitted were 5 out of 19, that is 12.5, and negative risk score and no readmission, no risk and no readmission is 10, so that is 25%. Whereas hospital score gave me scoring of out of 19, only 3 got like high score, which was more than or equals to 7. that is only 7.5%. The patient who scored positive score and negative score, the positive risk score and negative readmission is only 3, and that is 7.5%, whereas negative risk score and positive readmission is 15, which is 37.5%, and negative score and negative readmission is 19, which is 47.5%. So looking at these results, the modified LACE scoring risk score for readmission assessment was performed with sample size of 40, where 19 were readmitted, and modified LACE scoring model predicted 13 out of 19 readmission, which is 32%, which was the rule in. That means positive risk score with positive readmission, and 10, that is 25%, were ruled out, that is negative score and negative readmission, and 5, that is 12%, was only false negative, that is negative score plus readmission, whereas hospital score only has 3 out of 19 readmission with 7.5% rule in, and 19, that is 47.5% rule out, with negative score and negative readmission, and 15 out of 19, that is 37.5, was false negative score with positive rescoring. So overall, with these results, the modified LACE scoring performed better at predicting the readmission than the hospital score. This slide is a summary of the result. Since modified LACE scoring has 4 variables, and with 3 risk level and 57.5 prediction rule in and rule out. That is, rule in is positive score with positive readmission, and rule out negative score with negative readmission. It is 57.5%, whereas hospital scoring is 55%, and 10, that is 25%, where rule out, that is negative score and negative readmission, and only 12.5% false negative results. Looking at all these results from modified study, modified LACE score performed better readmission prediction than hospital scoring. So I would recommend considering using the modified LACE scoring tool to identify the patients that are at risk of getting readmitted within 30 days. The next recommendation is creating the individualized care plan. Discharge planning begins on admission, so assess the need of the patient during the admission. Focus on individual health history, not only admitting diagnosis. Engage patient and family in care during stay and transition, and appropriate referral, follow-up, and medication. This is applicable to all admitted patients. Next recommendation is involving the transitional care management. Aware the patient and inpatient nurses that transitional care management follow up the patient right after the discharge, and they have 3 business days to follow the patients. So if someone scores higher in the modified LACE scoring, then you can also give one hand off to the transitional care managers. So they are already aware who could be at risk of getting readmitted, so they can the transitional care managers can plan out to give more education, more support to those high scoring patients. Support patients to transition to the community setting by providing, if they have housing or any kind of food shortage or anything, provide them with community resources. It helps to prevent service gap, and transitional care management follows patient within 3 business days, and they all can follow up to until 30 days. They help in making outpatient appointments, getting referral, home health care, and so many things after the patients are discharged. And then also make those readmission scoring visible to transitional care managers, so they already have in the mind who could be the risk patient for readmission. And also this the transitional care management team could be helpful for all discharged patients, but they can give more focus on the patient who are at higher risk for readmission. Next, for the project evaluation, since even though I was not able to implement my project in clinical setting, I have listed the project evaluation using the PDSA cycle, that is plan, do, study, and act. So those involves objectives. The plan includes objectives and goals, plan data collection, plan first the cycle, like who, where, what, and where, and getting a project approval. Next is building the team, carrying out the plan, document the milestone, risk, and reporting it summary to the leadership in the study. It includes data analysis, result comparison with prediction goal, whether it's a success or the failure, and you can find what is working, what is not, what are the barriers, and after finding the barriers, in ACT you can like it will tell you what are the changes that might need, what would be included in next cycle, and it goes like it could go cycle 1, cycle 2, and the changes according. For example, if let's give example that we are using the readmission tool, and we have to give like plan to use. On the plan, we are trying to use the modified late scoring. We need to get approval from stakeholders, upper management, and we need to build a team for that project, and involve the leadership, provide summary to them, and after the nurses need to be made aware of it, give them training how to use it, and after the implementation, you'll have chance to find out if people and the nurses are actually using that tool. If not, why they are not using, what could be the barrier, like for example, if those tools are like it takes long time to do it, or they are complicated, or they don't have time to do it. So those you can find out after implementation, and then you can plan out. If those are too complicated, you can plan for next cycle, if you can modify some of them to make it easier, and if you can give extra support to the nurse, so those could include in the next cycle. And this cycle, PDSA cycle goes on, and the changes can be made according, like modified or changed according to the need. This is how we can evaluate the project. Next is project outcome. So for my project, the goals and objective were made from initial planning, and I was able to compare Montage Health readmission rate with Vision benchmarking. Chart review was completed. I was able to identify the common causes of readmission, also calculated and compared the readmission risk assessment tool, and also was able to find with the finding that modified LACE scoring did prediction was better than the hospital scoring, and also was able to recommend readmission preventive strategies. This project was perceived positively by leaders and stakeholders, since the organization does not use any readmission tool to identify patients who are at high risk for getting readmission. So using the readmission predictive tool can be one of the preventive method to lower the readmission rate. They were happy to see the results from the project, and they also said that it would be a good idea, and they would take a look into it, how they can implement those, but it had to go through like upper management and stakeholder. But overall, the project was perceived very positively by all the team members and the stakeholders. Let's go to the another slide, which is the achievement of quality and safety education for nurses competency. These are the achievements that I was able to gain, which are as follows. I was able to learn and coordinate an integration of the care, analyze my own strength, limitation, values, and ethics as a team member. I was able to explore like healthcare research methodology, evidence-based practice, and implementation information system. Had a chance to learn about the benchmarking and select the quality improvement benchmarking, and also had a chance to research on national patient safety measures for potential area of improvement and safety. The next slide is lesson learned. After this conduction of this project, I was able to identify the silos and form a collaborative partnership, standardize the care during admission and throughout and after discharge, need for risk assessment tool to identify high-risk patient. This is the organization-wide lesson learned, whereas also the lesson learned for patient needs and support was the patient support from nursing helps them for the self-management, and also prepare patient on admission for discharge can prevent the readmission. So these are my lesson learned from the project. There were limitations on the project since the sample size was small and there was limited time to collect and analyze the data, and also difficult to compare patient with or without the intervention, and it would have been more effective if I could have implement those preventive strategies in a real clinical setting, and also if I would be, it would be very helpful if those scoring tools and intervention were used in actual clinical setting. Let's go to the project summary. To summarize the project, this project was conducted in Montage Health, which is located at Monterey, California, and it was done over 4 months period, and it is 16 weeks. The aim of the project was to explore causative factor of the unplanned readmission and ways to reduce them. In United States, unplanned readmission cost $15 to $20 billion annually. And readmission is one of the quality indicator and center of Medicare and Medicaid services take it very seriously, and they penalize the organization if they have higher rate of readmission within 30 days of discharge. And proper identification of high-risk patient, coordination of the care, tools and resources are needed for the prevention of the readmission. Preventing unplanned readmission helps to improve quality, patient safety, and financial well-being to the healthcare organization. So if the organization can keep their readmission rate lower, then it helps everyone, it helps to improve patient satisfaction, and also it helps to decrease the healthcare cost and improve the quality of care that's provided in the healthcare organizations. So that was my last slide. If you have any questions or concerns, you can comment down below. And next slide is my references. So these are my references. And this is the last slide for the references. And I would like to thank you everyone for listening to my project presentation and giving me opportunity to speak in front of you. Thank you.